Welcome to today's session. The topic of this lecture is Essential ICU Medications for Nurse. I am Dr. Abdikhani Ahmed, and I will be your lecturer for this course. This course is specifically designed for ICU nurses to help you become familiar with the medications most commonly used in the intensive care unit. We will cover drug classifications, mechanisms of action, clinical applications, as well as key nursing considerations. The goal of this lecture is to help you better understand ICU medications, improve your confidence in practice, and ensure safer, higher quality patient care. In the ICU, medication management is one of the most critical aspects of patient care. Why is this topic so important? First, to ensure patient safety. Many ICU drugs are high-alert medications, and even a small mistake in dosage can be life-threatening. Second, to respond quickly. ICU patients often deteriorate or improve rapidly, so nurses must act fast in administering or adjusting medications. Third, to monitor effectively. It's not just about giving the drug. We must also know what to watch for, including potential side effects and laboratory changes that reflect the drug's impact. Finally, to prevent medical errors. With proper knowledge and skills, we can safely handle high-alert medications and minimize the risk of harm. That is why understanding essential ICU medications is fundamental to ensuring both patient safety and high-quality care. In the previous slide, we discussed why medication safety is so important in the ICU. Now, let's look at the main objectives of this session. First, to understand the pharmacologic classes of ICU drugs. Knowing the drug class helps us predict its mechanism and clinical implications. Second, to learn the clinical indications, monitoring requirements, and side effects. This knowledge is fundamental for safe patient care. Third, to recognize both common and severe side effects. Especially with high-alert drugs, early recognition can save lives. And finally, to improve safety and confidence in medication handling. The goal is for every ICU nurse to feel more competent and confident in dealing with medications. In the previous slide, we looked at the objectives of this session. Now, let's move on to the actual medication categories in the ICU. Generally, ICU drugs can be divided into four main groups. First, hemodynamic support drugs, Vasopressors, which are essential for maintaining blood pressure and organ perfusion. Second, sedatives and analgesics, used to reduce pain and anxiety, and to keep patients stable during procedures such as intubation. Third, electrolyte and acid-base correction drugs, which are critical for managing common electrolyte imbalances and acid-base disorders in ICU patients. And finally, antibiotics and miscellaneous drugs. Since infections are a major concern in the ICU, antibiotics play a vital role in treatment. In the following slides, we will go through each category in detail. In the previous slide, we introduced the four major categories of ICU medications. Let's now begin with the first category, hemodynamic support medications. These drugs are essential in critically ill patients to help maintain or improve blood pressure, cardiac output, and tissue perfusion. They generally include vasopressors, which primarily raise blood pressure, inotropes, which increase the contractility of the heart, and in some specific cases, vasodilators, which reduce afterload. Among these, vasopressors are the most commonly used subcategory. Their main role is to increase vascular tone and raise blood pressure, especially during shock. Common examples include norepinephrine, epinephrine, dopamine at higher doses. Vasopressin. These drugs are considered some of the most critical life-saving tools that ICU nurses must be familiar with. In the previous slide, we introduced vasopressors as the main subgroup of hemodynamic support drugs. Among them, the most important and widely used is norepinephrine, noradrenaline. Norepinephrine is considered the first-line vasopressor, especially for patients with septic shock. Its main uses are to raise low blood pressure, particularly in septic shock, to be given after fluids. If the patient remains in shock, it is recommended as the first-line vasopressor in most ICU protocol. Storage. Keep in the refrigerator, 2 to 8. It can be stored at room temperature for up to 24 hours and should be protected from light and heat. Nursing actions, what to do: monitor blood pressure closely and titrate the dose as needed. Always administer via a central line. Watch for arrhythmias, bradycardia, and breathing problems if extravasation occurs. Inject phentolamine, 5 to 10 milligrams diluted in 10 to 15 milliliters saline, into the affected area as soon as possible. What not to do. Do not use if the solution has turned brown. Do not give via wrist or leg veins. Do not infuse during halothane anesthesia. Do not give with inhaled anesthetics for ICU nurses. Norepinephrine is one of the most commonly encountered vasopressors, and mastering its safe use is essential. Another key vasopressor is epinephrine, adrenaline, which also has inotropic and bronchodilator effects. Main uses: cardiac arrest, ACLS, severe anaphylaxis shock unresponsive to fluids or other vasopressors as adjunct in bronchospasm. Nursing points: continuous BP, ECG, and HR monitoring. Use central line for infusion. Watch for tachycardia, arrhythmias, hypertension, chest pain. Avoid mixing in the same line with alkaline drugs, e.g., bicarbonate, using discolored or cloudy solution extravasation, since it is a vesicant. Next, we have dopamine, which works as both an inotrope and vasopressor. Its effects are dose-dependent, meaning action changes with the dose. Main uses: hypotension when fluids are not enough, bradycardia with poor perfusion, shock with decreased cardiac output. Nursing points: monitor BP, HR, and urine output continuously. Prefer central line for infusion. Watch for tachycardia, arrhythmias, chest pain. Regularly assess perfusion, skin, capillary refill, urine output. Avoid use in patients with tachyarrhythmias. Long-term use in peripheral veins. Risk of extravasation, mixing with alkaline solutions. The last common vasopressor is Vasopressin, an analog of antidiuretic hormone, ADH. It is usually used as an adjunct to norepinephrine, rather than alone. Main uses: as an add-on in septic shock, vasodilatory shock unresponsive to fluids, and catecholamines, esophageal variceal bleeding. Not routine ICU use. Nursing points: monitor BP, urine output, and peripheral perfusion. Watch for signs of ischemia, gut, skin, extremities. Report low cardiac output, decreased urine output, mottled skin, or cold extremities. Avoid titrating the dose without physician's order. Use in hypovolemic shock without fluids. Long-term peripheral infusion due to ischemia. Risk. Another vasopressor option is phenylephrine, a pure alpha-1 adrenergic agonist. It is often used as an add-on to norepinephrine. Main uses: hypotension, especially with tachycardia, neurogenic shock, spinal anesthesia-related hypotension situations where increased SVR is needed, perioperative or vasodilatory states. Nursing points: monitor BP closely due to rapid changes. Watch for reflex bradycardia, peripheral vasoconstriction, hypertension, arrhythmias. Ensure secure IV access to prevent extravasation injury. Avoid using in bradycardia or low-output states. Long-term infusion in small or fragile veins, combining with other vasoconstrictors unless prescribed. After vasopressors, let's move on to the second major group: sedatives and analgesics. These drugs are essential to keep ICU patients calm, pain-free, and safe during intubation, mechanical ventilation, and invasive procedures. Common drugs and key nursing points: midazolam, quick onset, watch for respiratory depression and tolerance. Propofol, short-acting, can cause hypotension, requires lipid tubing. Dexmedetomidine, light sedation, no respiratory depression. Monitor HR and BP. Fentanyl, strong analgesic, monitor for respiratory depression and constipation. Morphine, analgesia and comfort, causes histamine release, hypotension. Monitor renal function. Ketamine, preserves airway reflexes, increases HR and BP. Monitor for hallucinations. In short, the key role for ICU nurses is close monitoring of breathing, blood pressure, and side effects when using these drugs. Previously, we reviewed the common sedatives and analgesics. Now let's focus on the nursing responsibilities. When using these medications, nurses should use sedation scoring tools, e.g., RASS, monitor respiratory rate, SpO2, BP, HR, continuously balance sedation depth with pain control, check compatibility. When combined with other drugs, titrate to the lowest effective dose. Watch for tolerance, withdrawal, and accumulation. especially with midazolam. Avoid oversedation delays extubation under sedation agitation. Self-extubation giving without proper sedation or pain assessment. This ensures patient safety and effective ICU care. In addition to sedatives and analgesics, ICU patients sometimes require neuromuscular blockers. The purpose is to cause temporary paralysis, usually for intubation, mechanical ventilation, or to control severe agitation and shivering. Common agents: succinylcholine, depolarizing, very short-acting, ideal for rapid sequence intubation, contraindicated in hyperkalemia. Rocuronium, non-depolarizing, intermediate, fast onset, longer action, used for sustained paralysis. Vecuronium, non-depolarizing, intermediate, slower onset than roc. Dose adjustment needed in renal/liver impairment. Cisatracurium, preferred in organ failure, metabolized by Hoffman elimination, independent of kidney/liver. Key nursing points: always combine with sedation and analgesia. These drugs do not sedate or relieve pain. Monitor respiratory status and oxygenation closely. Consider onset, duration, and metabolism when choosing the agent. In the previous slide, we reviewed the main neuromuscular blockers. Now let's focus on the nursing responsibilities. When using NMBS, nurses must always provide sedation and analgesia first, since NMBS only paralyze muscles, monitor respiratory status and vital signs closely, provide eye care, as the patient cannot blink, prevent pressure injuries, and DVT. Since the patient cannot move, ensure ventilator settings are correct and alarms are on. Avoid giving without adequate sedation and analgesia using succinylcholine in patients with myasthenia gravis or hyperkalemia, relying only on vital signs to assess. Comfort: always do additional assessment. In addition to vasopressors, sedatives, and muscle relaxants, ICU patients often require respiratory medications to open airways, reduce inflammation, and support breathing. Common drugs and key nursing points: salbutamol, albuterol beta-2 agonist, bronchodilator. Watch for tachycardia, tremor, hypokalemia. Ipratropium, anticholinergic bronchodilator, often combined with salbutamol, fewer cardiac effects. Methylprednisolone, IV corticosteroid, monitor glucose and WBC, risk of hyperglycemia and infection. Dexamethasone, long-acting steroid, used in COVID-19 and ARDS, monitor for GI bleeding, mood changes. Magnesium sulfate, smooth muscle relaxant, for severe asthma. Watch for hypotension, reflex loss, and respiratory depression. In short, respiratory medications aim to open airways, reduce inflammation, and ensure safe breathing support. When using respiratory medications, nursing care is just as critical. Key responsibilities include monitoring respiratory rate, SpO2, breath sounds, and heart rate, especially with beta agonists. Correct delivery device: use nebulizer or MDI with a spacer for effective delivery. Oral care: rinse the mouth after steroids to prevent oral thrush. Assess patient response: watch work of breathing, coughing, and air entry, and always document effectiveness and side effects. Things to avoid: don't continue bronchodilators without reassessment. Don't skip mouth care after inhaled steroids. Avoid giving nebulized meds without proper precautions, such as aerosol protection. In addition to vasopressors, sedatives, and respiratory medications, ICU care must also address electrolyte and acid-base imbalances. These can cause arrhythmias, seizures, muscle weakness, or altered consciousness, so correction is critical. Key drugs and nursing points: potassium chloride, KCl4 hypokalemia, infuse slowly, less than 10 milliequivalent/HR. Monitor ECG, watch for phlebitis. Magnesium sulfate, for hypomagnesemia, seizures. Monitor reflexes, BP, and respiratory status. Calcium gluconate/chloride, for hypocalcemia or hyperkalemia protection. Use central line if possible. Monitor ECG. Sodium bicarbonate, For metabolic acidosis, severe hyperkalemia, monitor ABG, avoid overcorrection and sodium overload. Phosphate, KPhos/NaPhos for hypophosphatemia. Give slowly, adjust dose for renal function. 0.9% NS/lactated ringers. For fluid resuscitation and acid-base balance. Select type based on pH, electrolytes, and comorbidities. The key nursing principles are: infuse slowly, monitor closely, and avoid overcorrection. When giving electrolytes and acid-base correction, nurses must follow key responsibilities. Check recent labs, K, Mg, Ca, pH, ABG, before administration. Always use an infusion pump for electrolytes. Monitor cardiac rhythm, especially K, Ca, vitals, reflexes, urine output. Document dose, rate, and patient response. Use central line for irritating or concentrated solutions. Recheck levels after correction to avoid overcompensation. What to avoid? Never give KCl as IV push. It can be fatal. Avoid rapid infusion of calcium or magnesium. Don't overcorrect sodium or bicarbonate. Risk of osmotic shifts and alkalosis. Finally, let's look at some miscellaneous ICU medications. While they are not always life-saving in the moment, they are critical for stability and complication prevention. Insulin, IV/SC for hyperglycemia. DKA, stress response. Use sliding scale or infusion. Monitor glucose hourly and potassium levels. Furosemide, Lasix diuretic for fluid overload and heart failure. Monitor urine output, electrolytes, K, Mg, and blood pressure. Mannitol, for cerebral edema and high ICP. Use a filter, monitor neurological status, renal function, and serum osmolality. Heparin/enoxaparin, for DVT/PE prevention or treatment. Check APTT for heparin, platelets, and monitor for bleeding or HIT. Omeprazole/pantoprazole, for stress ulcer prevention. IV or oral, monitor GI symptoms, and magnesium with long-term use. In summary, these medications help to maintain stability and prevent ICU complications. When giving these miscellaneous ICU medications, nurses must verify indications and lab values such as glucose, potassium, and renal function. Key monitoring: insulin, monitor glucose and potassium. Diuretics, monitor urine output and daily weight. Anticoagulants, watch for signs of bleeding. Mannitol, perform neuro checks. Document dose, route, response, and side effects. Use infusion pumps and smart protocols where required. What to avoid? Don't skip glucose checks during insulin infusion. Don't push furosemide too fast. May cause ototoxicity. Avoid heparin in patients with a history of HIT. Don't co-administer PPIs long-term without review. This concludes our session on essential ICU medications. We have reviewed the major categories: vasopressors, sedatives and analgesics, neuromuscular blockers, respiratory drugs, electrolyte corrections, and other important ICU medications. The goal is to help nurses gain confidence in medication handling and ensure patient safety in daily ICU practice. Thank you all for your attention and participation. If you have any questions, feel free to ask. Thank you.